Okay, hello everyone. I'm thrilled to announce that I'm joined by Zoom. I'm with Matthew Siuba from the US. He's an adult intensivist at the Cleveland Clinic in Ohio, in the United States. And in 2020, he led an amazing article entitled The Zentensivist Manifesto, Defining the Art of Critical Care, along with other adults and pediatric intensivists. And since then, he drives many very interesting reflections on the art of medicine, education, and how to reduce the dead space in what we do in our clinical practice. So, Matt, thrilled to be with you. Happy to join, at least in this Zoom era of communication. Thanks for being with me.
Thank you for having me, Sebastian. I'm really excited to talk to you today.
So let's start with something simple. What is to be a Zentensivist? How did you came up with this idea of mixing the same philosophy and your clinical practice?
Yeah, it's interesting. It actually, just like how you and I know each other, it was a conversation that was born on social media. We started talking about the fact that a lot of the treatments that we have to offer didn't seem to have great, strong evidence behind them. And it kind of made people feel maybe a sense of nihilism about that. So we started to talk about it in more detail. And somebody said, well, maybe we're entering the age of the lazy intensivist. And I said, well, how about the Zen intensivist? That sounds a little bit more conversation is more in medicine for a long time, but this kind of just frames it in a more specific context that is maybe more appealing, just because it's got a little bit of an interesting edge to it with the name, rather than just saying minimalism.
So what is to be a Zentensivist? I mean, I have written a lot. There is this evolving concept within the intensive care unit about a change of paradigm between all is like permitted and change it through a less is more approach. What is less is more, and why less is more in your view?
Yeah, I think there's a few reasons. Number one, I think whatever we can do to minimize the amount of interventions that we inflict upon a person is to be advised. We don't want to do it in a way where we're being careless or thoughtless, but if there are ways to provide the same or better care by doing less intense interventions for people, then I think that would be the ideal, because then you have a balance of trying to restore the physiology back closer to a normal state, while at the same time not trying to coerce everything into a state of normalcy that is maybe not achievable at that point in time, and maybe not even evolutionarily appropriate. Just realizing how limited we actually understand adaptations to severe illnesses and the things that our bodies do and how they respond to them. I think it's always good to tread lightly when you are first encountering a patient. It doesn't mean you don't resuscitate people when they need to be resuscitated, but it just means you're doing it in the most measured way possible. And the behaviors that allow that to happen is actually a lot of things that I learned in pediatrics, because I trained in peds before I entered adult critical care. And a lot of those kind of thoughts of what's the least amount of things that I could do to somebody. I don't want to inflict unnecessary pain upon this person. And then just realizing that, again, the interventions that we have to offer are maybe limited in their benefits, so we should choose them very, very carefully.
In your clinical practice, did you feel sometimes that you were like annoyed on something? You might know this feeling that, hey, this patient doesn't need so many interventions. So perhaps that was how your ideas started to evolve, and try to join these ideas and exchanging these ideas through social media about, hey, if you stop for a minute and think about it, the less is more approach is evidence-based. You know, tidal volume, fluid overload and resuscitation, I don't know, red cell blood transfusions, and in almost every single field of critical care, the less is more is evidence-based. It's not just like it's your idea or mine that we have to do less. I mean, we have strong evidence about that patient will do just as fine with less iatrogenic disorders, doing less. So could you tell me some examples of your daily clinical practice of how sentensivists act, and how he or she, this sentensivist approach, how it evolves in the management of your everyday practice, you know?
Yeah, those are all great examples too, in terms of blood transfusions and, you know, even other things like oxygenation targets, CO2 targets, and ARDS and things like that, where we can kind of relax. I think the one thing that I always like to point out is when somebody is acutely unstable, then maybe the actions of a Zentensivist and a usual care intensivist don't look all that different, because if somebody is at risk of losing their life in the next few minutes or hours, then you have to do what you have to do to reverse that to the best of your abilities. But everything after that point, I think we have to question everything that we do. Do I need to check this lab so frequently? These are the kind of questions that I ask myself. Is this medication still needed? Do I need to check these labs as frequently as we're checking them? What is my expectation by obtaining this diagnostic study? How do I think that's actually going to change it? And then finally, am I doing this because it's the physiologically most appropriate thing for the patient, or am I doing it because I feel like I need to do something to show that I made an effort? And I think that's where sometimes people get stuck when they try to pick up some of these practices, these intensivist practices, because they are afraid to be seen or thought of as you know, being negligent or not doing enough. And I think that's where you just have to go the extra mile and explain why why we don't need to check the CBC so frequently. Why do we not need to obtain a CT for pulmonary embolism on every patient who comes in with respiratory failure? You know, I think that's when our abilities as diagnosticians really come into play. Because if you can reason your way through why something is likely or unlikely, then you don't have to necessarily exhaustively work up every single problem and make sure you make every lab in the computer turn back to a normal value so the red flag goes away on the chart, right? It's all about just having a appropriate context for what you're actually trying to achieve.
So I think a problematic thing that came up was that you published in 2020 the Zentensivist Manifesto, and then COVID-19 arrived. I recall that you published another paper about treading lightly in the wake of this new pandemic. What kind of exchange with other colleagues did you receive in 2020 when you were saying, hey, please, let's be quiet about this. Zentensivism still works or can work in COVID-19 crisis. But on the other way, every one of us was doing more and more and more interventions that, in the light of the new evidence, the emerging new evidence in the late 2020 and 2021, most, if not every one of those interventions resulted in being futile. You know, we can name many examples. How do you live as an intensivist during 2020 crisis with COVID-19?
Yeah, that was that article that you mentioned was born out of urgent, or feeling of urgency at the bedside, because I was struggling with seeing the things that we were trying. Everyone was getting really bizarre combinations of different drugs, whether they were antibiotics or immunosuppressives or things like that. And they were all, maybe had of course they had biological plausibility, but they were not proven. And I understand that we were in a state where there was, the feeling of this emergency to do something. But we knew going into that based on our history in critical care, that most of the things that we were going to test weren't going to pan out. Most of the things that we have tested, especially when you look at drug therapies in the ICU, it's very, very rare that a drug is shown to have a positive impact on patient important outcomes in ICU patients. So we wrote that in that paper, and it wasn't like a brave prediction or something. It was just like that's the fact of what it's like to provide ICU care. And the problem is when people were saying, let's make sure we give drug X or drug Y or drug Z, they were not, that was a distraction from what was going on with the patient. How about we focus on managing this patient's ARDS with best available practices that we already know? Why are we not, considering fluid management strategies like normal? Instead, we're like, what's the newest toy medicine that we can put out and see if it has an impact? And I think it was very appropriate to randomize patients into trials really, really quickly. But instead, we were just kind of trying things out. And I think as well as I do, we don't really know when something we do to a patient works. I mean, we can say, oh, I turned up their pressure so their blood pressure went up. I don't know exactly how that impacts the patient's long-term outcome. And I think the same was true for all these drugs. I mean, we were not even, the criteria by which the patients were selected for all these different medicines was very, very unclear. So the reception that we got from that paper actually was mostly positive, because a lot of people were like, yeah, this is kind of crazy. We're doing all these things. And then think about all the labs and things that people were checking. We had to check a ferritin and an IL-6 and everything like this all day, every day or every few days. I don't think I ever acted on any of that information. So my first task whenever I came on service was try to cancel all those labs, because I'm not sure what the point of this is. But it was a great opportunity.
Why do you think that happened?
I think
the abrupt change of practices, suddenly this was a different RDS. Suddenly we have to paralyze everyone with RDS. Suddenly we had to put on them these like lots of medications that we know that most of them will turn into medical reversals.
Yes.
So why did the intervention bias, this podcast is called Bias in Spanish. SESGOS means bias in Spanish. And I recall reading an intensive care medicine journal article, very interesting, that they stated that this was a pandemic of biases. Why did we fall in this interventional nightmare of while taking care of these really sick patients?
Yeah, I mean, I think there's an element of fear and desperation that I think we all felt. We were facing something that we'd never seen before, and we wanted to have answers for it. And I think it really does come down to what you said as an intervention bias. What if we said in, let's say, March of 2020, let's just wait until the randomized trials start before we start giving these medicines? I think there would have been a revolt, right? Like people would have been really upset. But it was the right thing to do, and I think, in some countries it's easier than others. I don't know how it is for you, but it's actually kind of difficult to get a randomized trial off the ground in the United States based on all the regulatory issues. So there's going to be some delay. So I understand the anxiety about that. But at the same time, you don't know that on any of those things were not going to be harmful. And in fact, some of these medicines that people thought were going to be no harm and maybe a benefit actually were probably harm with no benefit. And those are the things that, we could have predicted that. That was not something that would have been difficult for us to appreciate. But again, at the time, unprecedented, severity of disease and unprecedented volume of disease, I understand why it happened, but I hope we do better next time.
And how do you predict it will turn out? I mean, we almost surely will live another pandemic. We already lived two of them. We have the H1N1 flu pandemic. Now we had COVID-19. I predict that it's really easily to predict that in the next 10 years, you say, another virus will come up. It's biology. How can we be mentally prepared to be better than this time? Is that possible? You think in the ICU environment that would be really, really hard?
I think it'll be difficult, and I think especially if we encounter similar severity of illness that we saw, especially in the earlier waves of the pandemic, I think it'll be very, very difficult for people to show that restraint. That's where I think, like, institutional or even above that, like at a policy level, there needs to be some degree of Zentensivist, right? Like, I'm hoping that some of these large platforms that developed to study treatments for COVID will sustain for the next pandemics, and hopefully we can quickly enroll people and have answers in months, and hopefully have some patience about it. I think, as much as I'd like to say we could do it better, I think based on the pressures of human nature and also public expectations, it's going to be difficult to do better in the future, but I hope that we can at least make incremental progress towards doing better next time.
So in this way, what are the things you like to teach about Zentensivism for the future colleagues, for the future intensivists? What are the key aspects of Zentensivist at the bedside, but in the teaching class, in the teaching classroom?
Yeah, that's a great point. And I'm very happy that there has been a large amount of enthusiasm from young people, trainees, students, residents, fellows, and young attendings to want to adopt these principles. The one thing I always say as a disclaimer is, it requires clinical mastery. You have to really be able to understand trajectories of illness and natural history of diseases before you start to adopt this. Because if you come your first day in the ICU and you say, I'm a Zentensivist, I don't have to worry about that, and you don't have any context for it, you're going to do harm. It's not going to turn out. So usually what I try to do is, in those moments where you notice that some of the care that you're providing is bloated, like I say, like checking labs that are unnecessary or giving medications that are probably not needed at that stage, those are the opportunities for you to start to teach risk tolerance and clinical reasoning. And I think those are the two foundational things, whether you're as intensivist or not, we should be able to teach our trainees. The other thing is you have to model the behavior at the bedside. So if you're going to do less, you can't just say, no, that's not important. We're not going to do that, because then people think that you don't care. So what you really have to do is spend a lot of time doing what's called like metacognition. So you have to explain your thought process, why you're choosing to do something or to not do something that other people might do. And you have to do it for your trainees, but you also have to do it for the nurses. You also have to do it for the family and for the patients, because they will have expectations. Especially in the United States, there is an expectation that doing something to a patient is a good thing, because we like interventions and we like quick fixes. So you just have to take that extra few minutes to say, we're choosing not to do this, and the reason is I think it's more likely to hurt you than it is to help you. And when you say something like that, it's easy for people to understand that you're doing this consciously, and you're not trying to downplay the severity of their illness or anything that they're going through, but you're just saying, I think it's more likely I'm going to cause harm if I do this. I know other people might do it in this circumstance. And then importantly, you also have to lay out, if something does get worse unexpectedly, what's your threshold for action, right? Because otherwise it just seems like you're just saying, no, we're never going to do X, Y, or Z. No, I'm never going to give that patient any fluid. Well, okay, if something changes, then, if we reach this threshold for action, then we'll make a change. And I think all of that is what is necessary for people to pick up these skills, but it takes a lot of time and a lot of work. And so it's actually doing less actually takes more work.
It's much more difficult to do less.
Yes. Yes.
And how do you teach those intensivists or fellows trying to cope with this? I mean, you have this patient, you have adopted this less is more approach, try not to transfuse, try to not fluid overload, try to reduce the dose of your mechanical ventilation, or instead you choose to go for the non-invasive approach of the acute respiratory failure, and then your shift ends, and then you hand it over to another colleague, and within the first 15 minutes or half an hour, he or she, these colleagues, which you really appreciate and look up to, just go to the unit, intubate that patient, order the transfusion, and you think, yeah, you did it wrong.
Yeah, wow, that's one of the hardest situations in medicine. So I'm still only a few years out of training. So for me, I spent a lot of time reflecting on the care that I provide and hoping that I made the right choice. The problem is the feedback mechanisms that we have in medicine are so bad. You can do the right thing to the patient and they do worse, or you could do the wrong thing to the patient and they get better despite what you did. So it makes it very, very difficult to know what to do in those circumstances. So yeah, if it's somebody that you respect, who takes a more aggressive approach than you, then a couple things you have to ask. Number one, if it's somebody that you respect, you should be able to talk to them. You should be able to say, this is what I saw, and this is the reason I made this choice. And then you can kind of ask from a place of true curiosity. Can you tell me what you were thinking about the care of this patient and how you made the decision that you made? And I think that's all you can do. And then you can learn from them. And there'll be maybe some things that you can take away from that. And there may be some things that you learn that you would still do differently in the future. But that's where honest self-reflection has to come into play. And again, it is a very imperfect system, because there's no report card or no grading system for you took good care of a patient. And again, we don't exactly always understand what influences the outcomes of our decisions. So that is a challenge, and it will come up. I will say it is also useful for trainees to see people practice different levels of invasiveness and aggressiveness, because they can learn what they think is an appropriate, reasonable approach. So I think and again, I think diversity in medicine in all forms is a good thing, and diversity of risk tolerance and diversity of choice is also useful, because if I knew the exact right way to do everything, then we would never have a debate about anything, right? We would all be providing uniform care. But that's admittedly a tough situation, and it will cause you to second guess yourself if somebody does something drastically different than you did. The other thing you have to keep in the back of your mind, though, is, did the patient change? Because sometimes they will, and it could be within a half hour or an hour, and then that's a completely different scenario.
Totally. So one of the aspects of Zententivism is about humanism. Is it fair to say that we have to be humans again? Because one of the worst things, in my view, we did in the pandemic all around the world was keeping families out of the ICUs, out of the hospitals, while their siblings, sons, parents were sick in the ICU. Why we did that? And because that was one of the hardest part, to take care of patients for both the doctor and the families. It was like a two-edged harm that we self-inflicted, and we inflicted to parents and families. And I know that you introduced within the Zentensivist approach humanism, and families as part of the team. So how did you live this about keeping families out, and how can we bring them back?
Yeah, that was a really, really tough time, especially, fortunately, most of our, policies over time, at least locally where I am, have relaxed significantly, and we brought families back, I think, at a reasonably early time in the process, though still with some restrictions of visitation during certain times. Again, I think starting from a place of fear of the unknown, I can understand how it happened. But yeah, everything that, all the evidence we've been accumulating over like ICU liberation over the past decade or so has really pointed to the fact that having families around is really important, like just from a, medical, maybe perhaps a healing standpoint. But then, just think about somebody that's deeply sedated, gets into sedation interruptions, they wake up, they're in an unfamiliar environment, and no one is around who can console them or orient them appropriately to, their normal environment. That was very, very difficult, and I hope we never do that again. I think that you're right. That was bad. That was definitely bad for the patient. It was bad for the families, and it was also bad for us. And I think probably is an unprecedented time for the amount of phone calls that we had to make to people to say, well, your loved one's going to die soon and you can't be here for it. It's just completely ridiculous. So whenever possible, I tried to make exceptions to try to get families in, especially if somebody was actively dying or things. But, during active care, it was a little bit more difficult. But I think it was a good, it was a bad thing that happened, but it was a good reminder to us all how important that is. We learned a lot of lessons by learning by mistakes. So we learned, some people relaxed their practices around spontaneous awakening trials and spontaneous breathing trials because they were afraid, if you wake the patient up, they're going to desaturate, blah, blah, blah. And then additionally, we have the not being, bringing families in and trying to have an inclusive sort of environment for the patient. I think I hope that we learned our lesson on those items, because it is so important. It's easy for us in our role to get fixated on the physiology and the abnormal values to try to make them normal, pat ourselves on the back. We did the right thing. And we all got into intensive care because we like physiology. It's okay to be enthusiastic about it, but it only really matters if it helps the patient achieve the goals that they're hoping to achieve. And that's why humanism needs to stay at the center of Zentensivism and the center of the care that we provide, because otherwise what's it all for?
Totally. Matt, some time ago, another colleague, pediatric colleague from Africa, wrote that sometimes less is just less. And this thing about less is more approach is pretty doable when you have more. So less becomes a choice in a way. How do you think the less is more approach, the Zentensivist approach, suits in low and middle income countries? Is it feasible?
Yeah, that is a great point. I think not only is it feasible, it is probably optimal. And the reason is this. So if we can adjust the way that we consider, and let's say in a high resource setting, like the setting I work in, if we can relax the standards to being more reasonable and to what we think is appropriate care, then I think it makes it easier for environments who have less to not to try to have to strive to get a medicine to feel like they're providing optimal care to their patients if that medicine doesn't actually make a big difference in the end. And I think the WHO stance on remdesivir versus how we administered remdesivir in the United States was a good example. I still don't understand the appeal of it in critically ill patients. That's a story for another day. But, I think that those are the opportunities to say, hey, you're providing really, really high level care in low and middle income settings by doing less when it's appropriate to do less. Now, that article that you are mentioning that Jason wrote was great. And I think to his point, less is less when it's you can't provide standards because there's such great inequity. That's a completely different scenario. It's not like, you're in Africa and you don't have oxygen, so just accept lower saturations. Like, that's not the right approach, right? But I think in the well-resourced world, we can set a better example for what is appropriate care instead of just saying, hey, we can do more, so why not? I think that's the best that we can do from like where I sit. And for what it's worth, this is totally anecdotal. I found great enthusiasm from people who work in low and middle income countries about Zentensivism, because I think it fits more with the model of the care that they provide, and I think they're proud of the care that they provide because they can do the essential things right. I'm sure there are gaps, and these are things I can't speak to because I don't work in these settings. I'm sure there are gaps in ways that they'd like to improve, but it's, if you focus on the essential things, you can provide really excellent care, and we need to do that as well in our environments. We can't just add on any bell and whistle just because it's available to us.
Totally. Matt, what would be your advice for those intensivists who would like, after listening to you, to become a Zentensivist? What are the key aspects you mentioned about clinical mastery? You had to be really prepared to be active. I mean, Zententivism introduces the concept of being actively passive in a way. Just stand by the side of the bedside of your patients. What would be your advice for those people who like to join this path of Zen philosophy within the ICU?
Yeah, so I think the issue of clinical mastery, which you already covered, is essential. The next part is deciding how you can recalibrate your risk tolerance. And that a lot of that has to do with how effective you think the treatment that you provide is and how likely it is to hurt. So if you think there is little downside and huge upside to something, you're probably going to provide it, and that's appropriate. But most of the things that we do don't fit into that category. Most of the things are small upside and at least some downside. So part of it is recalibrating your risk tolerance. The final thing that I think is important is just that really focused observation. So if you're going to do less, you have to pay much closer attention to the patient. If I'm going to try to hold off on intubating somebody, I have to watch them really, really closely if I think they're at risk. If you just intubate the patient, then it actually kind of makes your job easier, right? And in some ways, not in the big picture of things, but in that shift, it makes your life easier. You say, okay, I know the patient's not going to crash and burn, and I can at least relax. They'll be sedated for a while. They'll kind of chill out. And sometimes that's the right thing, but you have to spend a lot more time coming back to the bedside, reassessing the patient and keeping an eye on the trajectory. And when I round, I try to see patients 3-4 times a day. If they're active, I really come back and check in a lot and make sure I understand where they're going. Because the other thing is, this is not, like you said, this is intentional passivity when it's appropriate. But if you see something's going in a bad direction, there's no reason you can't intercept it and act on it. Trajectory. I think disease trajectory is such a huge part of what we do in the intensive care unit, and really having a good handle on that makes it easier to decide when you can pull back and do less.
And moreover, you need a team, because if you are a Zentensivist, it does not work alone. You need a team of nurses, a team of respiratory therapists, if you have it, to work in this harmonious way. Try to give the patient just the things he or she needs and nothing else.
Absolutely. It's a team sport, and the patient and the family are part of that team, and you have to have everybody on the same page. Otherwise, it's not going to go well. Even if it goes well, it won't go well, right? You have to make sure that there's buy-in. You've at least created a microculture around that patient where you can provide the type of care that you think that they would most benefit from and lines up with their values.
Matt Siuba, real thankful to you for your time, for your passion on this Zentensivist approach. I hope many more colleagues join the team of the Zententivism, which is an evolving concept. So thanks for your work, and for your time today with me. And I don't know, let's see what happens in the next pandemic.
Sounds great. Hopefully it's not too soon. Thanks again for having me, though. Really appreciate the conversation.
Thank you. Bye-bye, Matt.
Bye.